Hi, I'm Dr. Nathan Patterson, and I'm going to talk to you today about breast reconstruction. Patients who are candidates for breast reconstruction are generally people getting mastectomies. The most common category is a patient with breast cancer on one side or both sides who wishes to proceed with some kind of breast reconstruction. Other categories would include patients who have congenital deformities of the breast, which can be male or female. Typically, health insurance does cover breast reconstruction surgery. In some instances, if a patient has had a previous cosmetic breast surgery and they have an outcome they don't like, insurance may not cover that. In fact, most insurances will not cover results or complications from prior cosmetic surgery. That's an important distinction because many patients are curious about this point and would like something done to make them a little bit better or more symmetric. But if the original surgery was for cosmetic reasons, most likely your insurance will not pay for any revision surgery. So breast reconstruction is either done as an immediate reconstruction or a delayed reconstruction. And what those terms mean is the following. Immediate reconstruction implies that under the same anesthesia in the same operating room as the mastectomy, the patient gets breast reconstruction. Delayed reconstruction, on the other hand, means that the mastectomy was done, the patient has finished the operation and recovered, and then typically several months later, or even several years later if they so desire, they come back for a second surgery, which would be a breast reconstruction surgery. So techniques used for breast reconstruction fall into several categories. The most common technique for breast reconstruction is some type of implant, and that may be what we call direct-to-implant reconstruction, where we simply put in an implant, or it may be what we call tissue expander reconstruction, where we place a temporary device called the tissue expander, which we slowly fill up with saline in the weeks that follow surgery until we can get the skin and the muscles stretched out sufficiently that it can then accommodate the full-size implant, which will be the permanent device later on. The second general category for breast reconstruction would be called autologous tissue, and what that means is using the patient's own tissue for breast reconstruction. There are various techniques for autologous tissue reconstruction, and there are various places to harvest the tissue. Frequently it comes from the abdomen, sometimes it comes from the back, other times it even comes from the thigh. Having said that, most of the time autologous tissue reconstruction is a complicated operation, and it carries the downside of having to have two surgical positions, one at the breast and one wherever the tissue comes from. Nevertheless, the second type of breast reconstruction is generally considered to be autologous breast reconstruction, or your own body's tissue without an implant. There is, in some people's way of describing things, a third type of reconstruction, which would be a combination of the two. That is usually a muscle or skin and muscle from the back used to create somewhat of a breast mound, but typically that is not big enough to make a very big breast mound, so we usually combine that with an implant as well, and that would be a combination of autologous tissue reconstruction with some sort of implant reconstruction. Now, one final thing about breast reconstruction is that people sometimes have heard about fat transfers or fat grafting. It is possible to help reconstruct a breast mound with fat that we harvest from somewhere on the body and then reinsert into the breast. What most people don't know is that fat transfers or fat grafting typically does not give you enough volume to recreate the entire breast. So instead of thinking of that as a way to skip the implant, rather think of it as a way to enhance the outcome when an implant or a flap is already in place. So a fat transfer is usually a secondary procedure done to help enhance the appearance, maybe make it look more natural or smooth out the contour after an implant is already there. So mastectomies can be done in various ways. For example, the old-fashioned mastectomy involves taking out the entire breast, some of the breast skin, usually the nipple, and maybe or maybe not some lymph nodes from the underarm position, so-called axillary lymph node dissection. Other ways to do a mastectomy would include preserving the nipple and leaving most of the breast skin intact. And there can be various incisional approaches for that, one of the more common being in the crease or fold underneath the breast. With regard to taking out lymph nodes, that really has more to do with the cancer surgery rather than the reconstruction surgery, but sometimes only a small sampling of lymph nodes needs to be taken out. And that, if that can happen, is usually good for the patient because it means a smaller surgery and a better recovery. For the most part, reconstructed breasts look great. They can look very, very much like normal breasts. The difficulties that can occur are in volume sometimes. Implants only come so big. The typical implant comes in a maximum volume of about 800 cc's. Well, 800 cc's may not mean much if you don't do this for a living, but a very large breast is typically much bigger than 800 cc's, and so there can be some limitation into how much volume you can get from a breast reconstruction. But as far as the overall shape of the breast and the overall symmetry, you can usually have excellent results with breast reconstruction. Recovery varies depending on what type of surgery is done, but typically with most surgeries that involve breast reconstruction, recovery is somewhere around 6 weeks. That is not to say that you're incapacitated until 6 weeks have gone by. Typically, most patients are doing very well by about the 2 to 3 week mark. Thank you for watching today. If you have any further questions, please contact us at pattersonplastic.surgery or call us at 850-484-7546.